Dear colleagues in Greece and abroad, it is my pleasure to welcome you to the 21st annual meeting of Hellenic American Psychiatric Association in connection with the APA annual meeting taking place today. This year, due to the COVID pandemic, we choose our meeting's topic to be the mental and moral aspects of the pandemic in our country, Ελλάδα, and the Hellenic Diaspora. For this reason, we are glad and honored to be hosting these distinguished scientists of our guest speakers, Professor Stephen Xenakis from the USA, Professor Argyris Tringares from Greece, and Dr. Anastasia Tsakiri from the UK. Before our HAPA Secretary, Dr. Georgios Pagkalos, presents our first speaker, I would like to briefly give the floor to HAPA's president and my dear friend, Dr. Philip Kandilis, so that he may welcome you to this meeting. Philip.
Thank you so much, Dr. Karampoutakis and Dr. Pagale. A real pleasure to have you bring together an extraordinary seminar for us today, and to have such good colleagues who can bring us such impressive speakers is a real testament to our working together at the Hellenic American Psychiatric Association. And thank you for scheduling it on such a difficult week, on Easter week, and your name day as well, to my friends, the Georgios, and so thank you for that. And you know, as we are still in the middle of the pandemic, and I'm in a public sector hospital, I'm particularly grateful that you've chosen this topic during the pandemic. I mean, we've had a lot to learn, and we still have a great deal to learn from COVID, but I think we have something to offer today, and this a great deal of good new information. Thank you, George. I appreciate it very much.
Well, happy Easter to all the attendants. Our first speaker is Dr. Stephen Xenakis. Stephen Xenakis is an executive board at the Center for Ethics and the Rule of Law, University of Pennsylvania Law School. Also, he's an adjunct professor at the Uniformed Services University of Health Science of the Department of Defense, and a program director COVID Resilience Campaign at the Silver Hill Hospital in Connecticut. Also, Dr. Xenakis is a Brigadier General retired of the United States Army. Please join me in welcoming Steve Xenakis. Steve.
Well, thank you. Let me share my screen with you. It's a great pleasure to be with you today. I'm having a little, let me try again. I'm sorry. I'm sorry also that my Greek is not better, but I will gladly. It's a great privilege to be with you. Let me get out of this. I wanted to speak today and introduce these ideas of moral injury as much to interest everyone in the conversation, because I think as we've watched this pandemic unfold, we know that it has really imposed a big burden on many of us, and particularly those of us who are caretakers, healers, and clinicians, as well as, of course, all of our colleagues and friends and family, as they've had to make the adjustments with the in the way that it has changed our configuration and our social life. The idea of, I'm having a little, okay, just for disclosures, I really have nothing that would be relevant to this presentation. My good friend, Jonathan Shea, has felt that in his book that he published in 1994, he coined the term of moral injury. that is now much discussed amongst those of us in the military and working with the military. I think we all know that the idea of the morality and ethics of what we do is fundamental to our work as doctors, and that it goes back thousands of years to the Hippocratic Oath. As soldiers, of course, it's also been very, very important, and it has informed a body of work that we call just war theory. There's when do you decide that what you're going to do that is going to have such horrific impact and cause a loss of life and death can be justified in terms of the morality and laws that govern our societies and govern our nations. There are those people, interestingly, for us as from a Greek background and heritage, that would say that the just war theory is a function or a derivative of Western Christian Roman Catholic thinking, that in fact we do not have in the Eastern Orthodox tradition. We do not, in fact, follow the same sort of guidelines and ethical principles as they do in the Western Christian tradition. And that's, I think, something to open up for a much bigger conversation at some point. But it's very interesting, and as I'm sure that many of us can search in terms of our faith tradition to understand that it would not be as easy for us to justify or rationalize what we do in terms of harming or killing other individuals. The definition of moral injury, as it has come about, has been that well summarized by a friend of mine, also Bill Nash, in a forward to a book on moral injury. And Bill and his co-author Krista say many of the themes that have coalesced in recent years around the concept of moral injury have been around a long time. The term may be relatively new to this context, but the central ideas are ancient, that there can be dire consequences for wrongdoing, both for the wrongdoer and for the wrong. That is, those consequences can endure for lifetimes and even ripple across generations. Some consequences are internal, like the painful and sometimes overpowering emotions of shame, guilt, and anger, or losses of the competency, value, and trustworthiness of our core selves. Other consequences are external, such as the losses of resources or social standing, or being expelled from the group, figuratively or literally. And that is an experience that many soldiers have, and particularly have going back to the Vietnam War, maybe going back, though, thousands of years. And I think that many of us in the healthcare field have also felt, as we've had to make choices and decisions at times when we have not had the resources, and particularly early in the pandemic, it was very difficult for the doctors and nurses to triage patients, to allocate their time and energy, to even know what would be the best clinical decisions. What really should they do when in fact the information that was available to them was limited? Sometimes the equipment that they need was limited, and it left many in this time with as many of our doctors and nurses. You can recall how the helplessness and despair that they experienced. It is that feeling is a core feeling here. It's that helplessness and despair that seems to endure and stay with people, that in fact can haunt them for many years, and probably sometimes haunts them for the rest of their lives. I'm sure we've all faced it in our families when we've had to make tough decisions about how we help out in caretaking as our family members, our loved ones has faced illnesses and other tragic circumstances. And so the impact on the healthcare workers is that it violates a sense of duty. What is the right thing to do? And when they've not had the resources, did they make the right choice. And unfortunately, many of those choices cannot be revisited. It's hard to replay them and hard to figure out, have I done the right thing here? Should I have done something else? And frankly, it's even hard to often be able to somehow work through the idea of and understand what the decision and choice was that was made at the time. I have talked with hundreds of soldiers, including many, many medics, both from the wars that I've been found myself with during the Vietnam War and during all our conflicts in Iraq and Afghanistan and others that have just had to struggle with a sense of, did they do the right thing at the time? And how do they know that they did the right thing? And is anyone going to be able to assure them that the decision they made was the one that they should have made? So there's a way of being able to describe this. And I think the first step in understanding what the impact is on us when we've been in those situations and how it has bothered us is to appreciate the various faces and the facets of how this moral injury is experienced, that it is continuous over time, that we live with it probably through all our years. I know that I've talked to many people who were in World War II and in the Korean War. I've talked to many doctors, of course, our colleagues who have struggled with understanding, did they make the decision? It's very difficult for everyone to feel that they can calm themselves, they can feel assurance, and that they have confidence in what they did. There's a sense of despair. More than once, finally, people get to the point of saying, there can't be any goodness. There is no God. There can't be any meaning. I mean, this really bothers many of our soldiers. And any of us who have worked with these men and women know that they finally get to the point that their lives spin out of control. I mean, they get themselves into a dark hole, and it's very deep and it's very black. They say, there's nothing I can do. And I've seen more than one that had decided to commit suicide, and somehow or other, God forgive that they didn't kill themselves, but there were serious attempts. With a sense of meaninglessness that comes in their lives and despair, there's a loss of trust. There's a distance from relationships. There's a disconnection. It really does contaminate almost everything. And very importantly, it affects and now changes their core sense of self. That what they did means that they are no longer good, that they can't be trusted. And I think it's not only amongst our soldiers, people have been in combat and been suffered in victims, and we have many of our colleagues and doctors and nurses, people that have tried to help, that have wondered, now, am I any good? Did I do the right thing? Should I continue? We have to recognize that this sense of moral injury by the people who are experiencing it is not the same as PTSD, and that particularly our soldiers and those in the military don't want to be labeled as having PTSD or depression or an anxiety disorder. They don't want to live with a sense that they're now in that kind of box, that it's a diagnosis and they'll be treated as if they're in that kind of box. They want to be able to understood that it's something bigger. It's something about them as people. And that very differently from who we think about and the way we approach PTSD or depression or anxiety disorders, or even complicated grief that for some way we've taken out of our diagnostic manual here in the US, is there's the sorrow and the grief and the sense of identity and the shame and the alienation that now really preoccupies their their daily lives. So on the other hand, the irony of it is that they want it recognized as an entity so something can be done and they can be helped. And I think that goes also for our doctors and nurses. They don't want to be labeled. They don't want to be stigmatized, but they want to get some help. So the impact is, as we've been trying to build the picture here, is that there are these persistent or recurrent negative feelings and situations that people re-experience what they've done. They relive the event. There is a sense of alienation and avoidance. And I think one of the most vivid scenes comes from the movie, came out about 10 years ago, The Hurt Locker, where the protagonist in that movie, he's in a grocery store with his young infant son, and he's saying, things aren't the same. Things aren't going to, he's talking to this baby. Things aren't the same. You're not going to feel the same. And the people you're talking to here in this world and when I come home don't understand and appreciate what my life is like. And I know that we've all been in situations that have been very intense like that, that we feel that. And anytime we've had it, perhaps it's vicarious trauma, perhaps it's re-experiencing that as people tell us about their lives, we know that they're feeling they do. And, very frequently people try and think that the way that they're going to handle that is with drugs and alcohol, which I think we all know don't really work. So that there are potential risk factors for folks, and I can show you a diagram here. The various people over the years that have said, look, that you've got professionals in various lines of work that are going to be more vulnerable to these kinds of emotions and the impact of these emotions, where they're in situations where life and death consequences, where they're working with people who are physically dependent and they only can look to them for their health, where they know that there's ethical dilemmas, where things are emotionally charged, where they feel that there's an expectation that they be perfect. And if they don't make absolutely the right decision, then everybody suffers something bad as the situation, where there are limited choices. We've all been in situations where we don't have good choices. We've had to make the least worst choice, and that's hard to live with, and it's hard to explain. But there's a sense of, there's a liability that comes with it, and it is very, very isolating. So the challenge is to be able to work with people, to understand them, to be empathic, and have them explain as to themselves and to us the gap of what happened and what should have happened. What is it that is really eating at me and haunting me? Because there is this, and sometimes it is really beyond, it is elusive, being able to explain and be able to elucidate that gap, to understand the values and norms that are experienced when it comes to that situation, and to hopefully help them abort some self-destructive behaviors. I think we have a lot of work to do, because I think we'll see that there are many people who are carrying the burden of what they've, with this pandemic, as well as a host of other situations that now feels that they've changed their lives. And I know people like to think that now there's a new normal, but that new normal means that what they've experienced has changed them forever. And that there are groups out there, and here in the US, we have the Veterans of America that have brought together, many of them are religious practitioners, people of faith, to help soldiers as well as healthcare people work through their moral injury, to process the memories, to know that there can be an empathic, caring relationship, and there's an acceptance, but it's very holistic. That it's along the lines that we all know of that the body really carries the experience of what's been traumatic and stressful and burdensome. I believe that there's a lot to be done and said about confession and religious ceremonies. Many of you may know a book by one of my teachers from my med school and residency, Jerome Frank, on persuasion and healing. And those religious faiths that have a way of the people going through a confession or being able to go through a healing ceremony does really relieve individuals of the worries and the anxieties that now have become part of their daily lives. Interestingly, my team is working with 2 different groups on the use of psychedelics, MDMA and psilocybin. And we have found that to be very, very helpful, particularly with soldiers. And what they do is they spend those sessions, when they take the drugs, it's about 8 hours, they really talk about their experiences and are able to get enough distance or in a different perspective that they can think about them in a much more objective way and view it all and know that there's someone that they've talked to and shared that experience. And that, I think, has been very helpful. So I appreciate the opportunity to talk about this because it is obviously, perhaps as you've sensed, it is a big part of what we do as military physicians and psychiatrists, is we work with the people who have been in the hardest situations. We work with the people that have been in the ugliest kinds of circumstances. And we know that now what they've seen and what they heard has been embedded in their minds and in their souls, in their thinking and their feeling. And I think that we as healers, as doctors and nurses, should take a lot of time to acknowledge that a lot more in what we do to help all the people that were coming to us. So thank you very much, and a happy Easter. Kalo Paska. Any questions? I'll be glad to take now or at the end of the presentation.
At the end, thank you for Professor Xenakis for your valuable insight on moral injury. You can send the questions for Mr. Xenakis. Now, on behalf of everyone in HAPA, it's our joy to have our next speaker with us, Professor Argyris Strigaris. Professor Strigaris is a senior investigator and chief of section of clinical and computational psychiatry at the National Institute of Mental Health. He is a professor of clinical psychiatry at Georgetown University, a visiting professor of psychiatry at King's College in London, and president-elect of the International Society for Research in Child and Adolescent Psychopathology. And today, he will discuss with us the consequences of the COVID pandemic on youth mental health. Argyris, thank you. You are with us.
Thank you very much for inviting me. Christos Anesti to everybody, and Chronia Pola to you, George. Thank you very much. It's a great honor to be among such an illustrious panel of speakers. Indeed, the topic of my talk is going to be effects of the pandemic on youth mental health. So this is going to be a very data driven talk. So these are people from my group. It's a mixture of clinicians and data scientists. And our motto is, in God we trust, all others must bring data and statistics. So the first question is, this is the outline of my talk. The first question is, why should we care at all about youth mental health? Well, that's an easy one to answer. Mental illness is the leading cause of burden of disease. And I'm saying this just in case you find yourself in a dinner party when the pandemic is over and one asks you, well, why youth mental health? Well, you could say unipolar depressive disorder, so garden variety depression, is more burdensome, leads to more disability in adolescence than anything else, literally anything else that can happen to an adolescent. And if you were to add together mental health problems in that age group, they would vastly outnumber anything else that can happen to people in that age group as a cause of disability. And that is true worldwide. What you can see here is disability adjusted life years lost. Someone still has their microphone switched on. Would they mind switching it off? Because I think there's interference. Thank you. And what you see on the y-axis is unipolar depressive disorders, road injuries, iron deficiency anemia, HIV, AIDS, and all sorts of other problems. And unipolar depressive disorders in both males and females is much more burdensome, causes much more disability, I should correctly say. And even road injuries, for those who know, are often the consequence of mental health problems, such as ADHD and impulsivity. So it's a huge burden of disease that happens early in life. And part of the reason why mental health problems mental illness is disabling is because it is chronic and largely persistent. About 75% of adult mental health problems have that onset in adolescence. The peak age of incidence in many psychiatric disorders during the transition from childhood and adolescence to adult life. And children are particularly vulnerable to pandemic effects. For example, school closures or loss of friendship and other sources of positive reinforcement. So you will read in the papers everywhere. I haven't put that in here because it will be very familiar to you. And as I said, I've tried to keep this as data focused as possible. You'll read it in the newspapers. You'll read it in the United States. You read it in Britain. You read it in Greece. People talk about a pandemic within the pandemic and paint everything in very bleak terms. Well, is this true or not? So what is so interesting then about COVID and mental health? Well, there's obvious public health reasons why we should care about COVID. Past evidence indicates that emergencies, disasters, and pandemics have negative impacts on mental health. That's pretty clear. On average, right? Health and socioeconomic impact of SARS-CoV-2 is great and therefore expected to have a negative impact on people, for it to be traumatic, as people say. And experts, and I included myself in some of this initially, and I have to confess this, that I expect huge rises in mental health problems. I quote here from a paper about suicides, and people were expecting a rise in suicides in during the pandemic, in the early phase of the pandemic, of about 150%. So those were the numbers we were expecting at the time. We were hypothesizing that. Were we right or were we wrong? And this is the important question, of course. From a science point of view, the pandemic, of course, is a natural experiment. It's a way to assess the causal impact of an environmental event. It's not very easy to assess the causal impact of an environmental event. It's very hard, actually. And this is pretty much as close as one could get to at such a large scale. So it's quite amazing, actually, to be able to do this, tragic as it may be, of course. So, okay, so youth is important. The child is the father of man, as Wordsworth would have it. So COVID is interesting for mental health. Let's look at some meta-analytic evidence of studies so far. As you know, meta-analyses are studies that pool together the effects that have been found in other studies, right? So they pull them together statistically. So randomized control trials would be the best studies to have. Well, you can't randomize people to having the pandemic or not. Then the next best thing is to have studies of temporal variability within a person, so pre and during the pandemic. Then you could have studies of geographic variation across populations. That would be another permissible design, or studies of variation within populations, or retrospective studies. The best one we can do is studies of temporal variation within persons, and that's what I'm going to be talking about today. The rest, perhaps with the exclusion of the geographic variation is a little bit of low quality, and I wouldn't bother with it too much, to be honest, for most instances. So let's go then to the meta-analytic evidence. This is something that was published pretty recently by an Italian group and showing the worldwide effects of the pandemic on mental health, and finding these are individual studies on the y-axis. This is a typical forest plot, as it is called, of the meta-analyses. These are the effect sizes of individual studies, which, for all intents and purposes, you can interpret as fractions of standard deviations. And what you can see here is the pooled overall random effects model. And what people found in this study is that the effect size of the difference between the pre-pandemic and the pandemic around the world in those studies that have been done, the effect of the pandemic on mental health, if you compare people before and during the pandemic, is there. It is significant. There's a significantly negative effect, a bad effect, if you like. But the effect size is pretty small. So it's less than 0.2 of a standard deviation. That is by no means huge. If any one of you has a bit of an intuition about effect sizes, then they will know that. And, you know, according to the kind of rule of thumb, this would be a small effect size. I'll come back to the interpretation of effect sizes later, though, because there are some important considerations about it. So just bear this in mind, that this meta-analysis, which is a good one, it's well conducted, found that. We started doing our own, and this is my great colleague, Dr. Dylan Nielsen. He's my staff scientist at our laboratory, and we put together more studies than the previous meta-analysis did, and we found again a slightly bigger effect, perhaps, but with a fair degree of heterogeneity. And again, the effect size was 0.3 of a standard deviation. That was a standardized mean difference. Again, not huge, rather modest effect sizes. And you will see that there are some studies here in which there was no difference. Those are the ones that cross the line. This is the line of 0, of no effect. There's a fair number of them. And there are also studies that, for example, this one here in Germany, that showed a positive effect of the pandemic, and another one here from China. So quite an interesting state of affairs. These are in adults and adolescents, actually. And Dylan broke down the meta-analytic effect size estimate and found it to be, for there to be no big differences in depression, for there to be differences in anxiety, as you can see in this graph, and found differences between the early phase of the pandemic and the late phases of the pandemic. Now, a brief pause here, just to consider the following situation. There was a significant correlation between the effect size reported in the study and the degree of media coverage it received, which means that the bigger an effect the study found, the more likely it was to be picked up by journalists and people who work in media outlets. So it seems like we find some evidence, at least, that negative effects are, of course, reported much more. This is a meta-scientific point, but an important one, and perhaps an important moral point as well about reporting of the effects of the pandemic. There's another point now I want to make, and this is, let's look at actual data from our characterization treatment study of depression in adolescents, the so-called CAT-D study. This is what we called it, and one of our research assistants drew this very beautiful little cat here. It's the shape of a brain. So this is a study that we are conducting at the National Institute of Mental Health, and it looks at brain, behavior, and biological samples. I shall not be talking about the brain tonight, but just about behavior. So I'm going to be talking about the assessment of behavioral changes using interviews and questionnaires, and leave out, for the moment, at least for tonight, data with functional magnetic resonance imaging and magnetic encephalography and anything else. So we're talking about 194 patients, an average age of about 16. This is the sex composition, and these are the diagnostic groupings. HV stands for healthy volunteer, and MDD stands for someone with major depressive disorder. So we looked at, I'm going to be showing, we looked at all sorts of things. So I'm just showing you fractions of some of the data. So we're looking at the mood and feelings questionnaire, the screen for childhood anxiety and related disorders, scared, and a survey that I developed together with some colleagues very early on in the pandemic, colleagues from the NIH and Child Mind Institute, which is called the Coronavirus Impact Survey. These are depression scores and these are anxiety scores. And what you can see here is that we have lots of observations. So we asked basically our participants several times before the pandemic and during the pandemic about how they felt. There are several advantages to asking people several times during a time course. One is that of course increases the precision of the measurement, decreases the standard errors, the errors of the measurement, but it also it increases your confidence about the longitudinal trajectory, because it isn't just a snapshot of some point in time, but rather an actual trajectory. So we're very pleased about that. You can imagine that this was quite a hard thing to do. So we, the clinicians of the study, and actually the people who were in the front line of collecting these data, were doing a tremendous job. So Dr. Tobin and the team of clinicians has done a tremendous job in collecting these valuable data during the pandemic. So, and we have 8 waves that I'm going to be presenting to you, 8 waves of data that were collected within the pandemic, which I think is quite a big thing. So we have wave 0, okay, and then the 8 waves within the pandemic. So wave 0 are all the measurements that were done in individuals between August 2017, when I started the study. I joined the NIH coming from London in 2016. So in 2017, we launched the study, and we took March 17th as the start of the pandemic, which was the date that the WHO declared it to be a pandemic, and then 8 measurements since. All right, so now another brief pause here. Again, this has to do with what we report and how we report. So in the papers, you will all, in the popular press, you will often read about disasters and changes. Now, many of these studies report an undeclared non-longitudinal studies. So having asked someone about their perception. So, and here we did something which I think is quite interesting. We said to people, how did you feel? How were your emotions? How was your mood before the pandemic? We asked them during the pandemic. This left side of the graph is during the pandemic. We said to them, how was it for you before the pandemic, and how is it now? And what you will see here is that they would say, oh, I was actually so much better before the pandemic. The higher the score, the worse. Now I'm feeling much worse. So they're saying, when you ask them to retrospectively assess their mood 3 months prior, they say to you that it was better. The problems, the emotion problems were lower. Now, we actually, though, as I said to you, have data about how they were feeling, what they were reporting pre-pandemic, and then also during the pandemic. And what we find is that there was actually no difference immediately at the beginning of the pandemic. So just to repeat this, because it may be hard to get one's head around, this is the perception of how they felt before the pandemic compared to the pandemic. This is the same rating taken before the pandemic and at the beginning during the pandemic. So you can see the disparity. There's a difference there. There's no difference here. So it's so much about perceptions. Okay, now this looks like a busy graph. Do entertain me, do humor me for a moment, and I'll walk you through it. These are depression scores here on the y-axis, reported by the young people themselves. On the x-axis, we have days before the pandemic. So all the negative numbers are the numbers before 0. here, and they are the days before the pandemic. All the positive numbers here, so the right-hand side of the graph, are the days after the pandemic. And blue are people with major depressive disorder or a history of major depressive disorder, and red are people who have who are healthy volunteers. And what you see here, those lines, those thicker lines, are model-based averages, and these are the trajectories of individuals broken down in males and females. As you can see, so this is called the spaghetti plot, and you can see why this is called the spaghetti plot. These are like spaghettis here. And what you can see is, or at least what I can see, is that there's no huge discernible pattern here. It's not like there's lots of people going up or going down or something like that. On average, there does seem to have been an increase in both males and females during the pandemic in people who were depressed, not in healthy volunteers. But at no point did self-reported depression during the pandemic exceed the levels of self-reported depression before the pandemic. So in other words, not much change. This is depression as reported by the parents on the y-axis. Again, time on the x-axis, same convention. Blue is for depression, red is for healthy volunteers. And as you can see, there isn't an increase of depression scores, of children's depression scores as reported by their parents. Let's turn to anxiety. It was the same thing. We did not find any increases in self-reported anxiety during that time frame in our patients during the pandemic. And the same is true about parents reporting on their children. I'm not bothering you, anyone who has an interest in discussing the intricacies of the linear mixed effects models. We can go in detail to that, but I think the graphs speak for themselves. There was no difference. Yes, there were individuals like this one here who shot up during the pandemic, but there were individuals who shot down in a pretty similar way, and there were also people who were just shooting up before the pandemic or going down. So in other words, we did not find in our study here a reliable pattern of change during the pandemic. And I repeated here, this goes against my own hypothesis at the beginning of the pandemic. But that's what we found. Now, were we the only ones? This is another paper I had the pleasure of being part from the, together with one of my tutors at King's, Sir Robert Plomin, who's a very famous geneticist and has this fantastic twin registry. What the study showed as well, we had data before the pandemic and during the pandemic. And again, what it found was the mean change from time point 1, i.e. before the pandemic, to time point 2, where if anything modest and inconsistent, just as many changes were in the positive as in the negative direction. And not only that, but the twin analysis revealed that genetics accounted for about half of the reliable variance at both time points. So genetic factors accounted also for a lot of the phenotypic stability. In other words, about why people remain stable or changed. So the environment played a relatively little role in those data. Now, he had collected those data early on in the pandemic, I hasten to add, but still there, so quite interesting. We had a number of other papers that I could talk about, but the point is that according to the meta-analysis we have so far and the data that I showed you, and I think our own NIH data with their shortcomings, and there are a few, such as the representativeness of the sample, do not support a vast change in mental health up to a certain time point during the pandemic. I'm not drawing any inferences about whether the pandemic itself will have negative consequences. Those may very well still occur, but at a later time point and be the consequence of all the economic hardship and the accumulation of potentially traumatic events for people, such as the death, the loss that people have suffered in particular parts of the world. But I just want to go back to a point that I made earlier. This is a bit of a more quantitative part of the talk. So I'll try to kind of also explain it in plain words. So I'm going to give you the gist of it in one sentence, I think from the outset, before I explain it in a bit more detail. Even what we call small effect sizes, like an effect size of 0.2, for example, which is by all accounts small. If this is happening across the general population, then that can still have quite dramatic effects. And we can demonstrate this using a very simple simulation. Let the true mean depression score pre-COVID on a questionnaire, such as the one that I've been talking to you about, be 6.5. And let it have increased by just 0.5, a difference that's clinically not meaningful if you were to encounter it in a clinical trial. And assume a standard deviation of about 7. These are real numbers. They're pretty plausible numbers. And assume an inverse Gaussian distribution. This is just how the data are distributed, and it's a pretty reasonable assumption as well. Then that half a point would be absolutely negligible around the mean. But it has, because of the properties, because of the mathematical properties of distributions like this, there would be huge. So you can recognize that this inverse Gaussian behaves a little bit in its distribution like a Gaussian curve, right? So except we don't have negative scores for obvious reasons. So think about it here as, and psychiatric scores are typically left skewed. So we would have 12% more cases with just half a point difference. But, and this is staggering, we would have 30% more severe cases. And again, let me explain this. This is just because of very simple mathematical properties, we would have such big differences. Now, if we had 2 points of a difference, which again is just 1/3 of the standard deviation, which is a ridiculously small, it's a very small effect, so about 0.3 in Cohen's d terms, we'd have 44% more cases and 200% more severe cases. Can you imagine a healthcare system that has to deal with about a 50% increase of cases, let alone with 200% more severe cases? So even those small differences can have vast impacts at the population level. I've plotted here the increase in risk given various mean differences, and it's okay, I don't need to go into detail with that. I will end on a positive note and say that there were also many positive things that our participants reported to us during the pandemic. And these are just some. People said, and there was lots of people who said that more time with my puppy, more time with family, and a new puppy, and people got a new puppy and they were very happy. More time with family, closer relationships with family, things like, oh, it was the first time that my father was able to sit at the table with us. We hadn't seen him. We would only see him for 10 minutes in the evening or in the weekends. More free time throughout the day, motivation to focus on myself, less school-related stress. And people mustn't forget that, at least for the current generation, you know, for many children, school can be quite stressful. So, especially in the beginning, when there was a break from school, it was perceived as a very positive thing by many children, especially those very anxious. Now, things have changed now, and what we see is children wanting, loving to go back to their school. So things do change. Anyway, on that note, some notes about the future. What will happen next with the pandemic, as I said? How will return to school be like? And I can tell you already that many children are struggling to go back to school with school phobias and other issues. And what are the real life consequences of the pandemic going to look like, such as the economic hardship, the joblessness, and all that, particularly in of our society, the more disadvantaged ones. So I think we should be braced for problems. This is my hypothesis, but take it with a pinch of salt, because my hypothesis at the beginning of the pandemic was proven wrong after all. And that's the nice thing about data. Thank you very much for the invitation, and I should stop here.
Thank you, Professor Strigaris. And now we go on with our third presentation by Dr. Anastasia Tsakiri. doctor in Orion Hospital and Nova Psychiatric Intensive Care Unit, Hammer at the NHS Foundation Trust, and she will talk us about the impact of COVID-19 admissions in General Adolescent Unit in the UK. Please join me in welcoming Dr. Anastasia. Anastasia.
Hello all. Thank you for the invitation. And as George said, I will just sharing with you my presentation. Can you see it now, please? George? Can you see my presentation?
Yes.
Yes, we see.
So yes, thank you very much for the invitation. I was the presentation of Dr. Strigaris was impressive, I must say, and all positive news. Now we are going to just guide you to another word, the word of the inpatient admissions and the impact of COVID-19 pandemic on admission in general adolescence units in UK. So who am I? As I said, I'm Dr. Anastasia Tsakiri. I'm consultant psychiatrist in both general adolescent unit in Hamburg Center and at the Nova Psychiatric Inpatient Unit. We Aspire, as we called our hospital, opened in admission in January 2020. So we're quite a brand new unit, and just before the COVID-19 pandemic started in UK. It was quite an impressive project because this unit was created after a public competition, and it was a huge investment, and part of that was to lead to better outcomes for young people and reduce the length of inpatient admission. However, the COVID-19 pandemic happened, so everything changed after the first month that we started. We had, of course, the first lockdown, the second lockdown, and the third lockdown that just ended the last month. As I think Dr. Strigaris said, we all talk about some kind of psychiatric pandemic that we're supposed to wait that is coming, or are we just still in the middle of this psychiatric pandemic? But we don't have realized what it's about. However, what we clearly seen in UK the last year was that there are a lot of mental health risk factors that increased. And this is about, of course, family relationships, strained family relationships, reduced social contact, academic stress, abuse, and the accessing support. I will go just briefly through that because I think it was discussed even before. So yes, we've seen that some things is getting worse, some things getting better. So there are a lot of research, a lot of surveys that are happening right now in UK about this. So yes, the family relationship is a little bit of a strange paradox because there are, as you see, 50% of parents in a survey reported that their child was expressing emotional distress. 31% had observed an increase in aggressive behavior. However, they all say that the family, this period of time was spending more time together and they improving their relationship with their child. Of course, another factor that had a huge impact in our young people was the reduce of the social contact, part of the school partnering that they couldn't go out, and of course this high level of loneliness that I think we all experience through this through this pandemic. Another factor that was changed during the COVID-19 pandemic was the academic stress. I think that students went through a lot of different kind of school attendance, like no school at all, then going through video classes, through Zoom, through courses that they had only seen online, and then they were just starting coming back to school. We had a huge difference of what's happening since the beginning of the pandemic. However, the most stressful thing about our student was about the future, their future of what is happening if the schools will close again, what is happening if they just cancel all our GCSE or A-level tests. And we've seen an increase of suicidal ideation, low mood, depressive mood, reporting more self-harming behavior. And this is very interesting. It was not through the young people that they were under the radar of the CAM services and child and adolescent and mental health services in UK, but there were young people that they had never been in contact with these services before. Of course, abuse, I think there was, if you just notice some of the UK news that they were saying that, of course, there was the referrals of safeguarding, the safeguarding referrals was increased massively due to, and lots of that was due to domestic violence. And of course, the services was not ready to deal with this kind of the high referral, safeguarding referrals. And they were saying that there's a huge increase compared with the same period in 2019. What is CAM services? Because I think I talked a little bit, a lot through the previous slides about what is happening with the CAM services in UK. So as you understand, we have, as we say, the community services that people can approach through the GP or through school. We have the, of course, outpatient clinics in the general hospital and side by side with pediatricians. Of course, some kind of mental health approach happening at schools and to GP practice. We have, of course, the young offending services, we have the children's centers, and we have independent CAMS professionals. And of course, we have the specialized inpatient units that could be day patient units or sometimes outpatient, or sometimes can be locked inpatient units. And what is happening? So I'm part of, as I told you before, we're part of a brand new unit that started just before the first lockdown. And we're expecting, of course, a huge rise of admissions. And it was the first shocked. We're shocked as well. We didn't know what to do, admit the patient, not admit the patients, trying just not to expose to any kind of contacts with professionals or other patients in the hospital. So we're at the beginning, we're actually in a very strange situation, but we've seen actually a reduction in the referrals the first couple of March, April 2020. Actually, the Birmingham Hospital that made a research about that, they were saying that it was actually a 50% reduction in the referrals. We didn't expect that at the beginning. We're expecting actually the opposite, but this is what happened. However, after that, we just experienced that many services have been reduced or suspended at the time when the children and young people are experiencing high level of anxiety. So there was no staff to be accessed and then to complete the Form 1 for the inpatient admit. Form 1 is like a document that external agencies have to fill in with all the relative information from for the young person difficulties, and then the hospital has to just assess this Form 1 and in 1 hour to give the answer if we're going to admit or not. And if we don't, then we have to give recommendation what to do next. However, as we said, we see that this reduced access to mental health services had actually created more anxiety to parents and young people, because they didn't know where to go, what to do, okay, and how to approach the mental health services. wasn't sure if they have to go through the GP service to change completely the way that they assess the patients. So most of them, they ended up in A&E service in the hospital, emergency services. And this is what happened after the 3-4 months of the beginning of the pandemic. The doctors that they were just working in A&E, they were saying that they have two kinds of patients. They had the COVID patients, that they're the huge percent, and then they had the mental health patients, sometimes going on under suicidal attempts or increase of self-harm behaviors, that they didn't know what to mental health hospitals. So we had, after the, as I said, 3-4 months, we have a huge increase of the referrals and admissions, especially during the third lockdown. The third lockdown was quite a difficult time for the inpatient units in UK. We had most of our young people under section, that means under the Mental Health Act law. So they were not informal patients. They were not patients that they came as with their volunteer to come to for take the help that they need in the patient units. And Section 3 in UK means like long-term admissions, more than 6 months, up to 6 months admission. So with severe level of mental health difficulties. What we just need to change the length of admission, although this unit, as I said, the first place was just to reduce the length of admission. And actually, for a couple of months at the beginning, we managed that. It was 24 days length, that is quite good in UK, I must say. We've seen that our admission was longer, was more than 2 months. And that was part of, you know, a lot of staff was going on of sick, so we didn't have services, outpatient services to deal quicker with these young people. We couldn't manage to do safe discharge in the community, so went up to keep them all in the hospital. We have to change all our way that the approach of the treatment in our inpatient units. So we couldn't give leave, for example, to our young people to go home a couple of days and come back to test if everything is okay at home, just parents to feel more comfortable with the young people that they are ready to be discharged, because we had to go through all what we are going to do if you know, these young people goes to their family home and then being exposed to the virus, and then come back and we have an outbreak of the virus in our inpatient unit. So a lot of decisions that we had to make that we haven't faced before. For example, then we realized that probably we cannot stop leave to young people. So we had just to adapt our way, and we found a way that, okay, then we'll test them, they will give me leave, but they will come back, they will isolate in the high dependence unit that we say within a hospital, and test them until they come negative, and then they can just go to their room. Of course, we stopped visits. That was another part that was quite difficult, because we stopped even parents' visits, and everything was going through video calls, that it was so difficult for these young people, you know, to just see their parents to the video call and nothing more. Then we had to adapt, and they were saying, okay, one parent will come at a time and with full PPA protection. Of course, all this period of time, it was quite stressful for the staff, quite stressful for the professionals, for the medical team. We had lots of less staff during this period due to infections or people isolated. We had to deal with emergencies without having more than one nurse on shift. So we had to adapt our therapeutic model, psychologists that they were in one ward, they were just couldn't go to another ward. They had to sometimes to join our meetings through from home, working from home. Lots of things that make us to reflect and think what we can do differently. We had also train the training for emergency COVID outbreaks. So we had to deal as a unit that anything happens to our patients, unless they need an ICU, we have to treat them with the COVID-19. So it was a huge stress, of course, the psych staff to going from like deal only with the mental health problems, just to go through that, wearing scrubs, masks, social distance, and try to deal with everything really. Meetings were more than through Microsoft Teams for the inpatient staff. It was quite an unusual situation because we were all at the same building, but everybody was in their office with a screen, joined the meeting with the screens. What else we've seen is like, especially the last period of time, I must say, after the third lockdown, it was high cuteness income services. That means serious incidents, ligature attempts, staff had to intervene, physically intervene, restrain patients, and this made expose both staff and the young people to even take the virus, you know, but we had just to prevent further harm. Of course, we went through, after October, November 2020, we went this ongoing habit, not even a habit now. It was necessary, but then became a habit to have this rapid test every 2 days. Everybody's with a kit of rapid tests going around in the hospital. And of course, as I said, change of a different way of working, working remotely, working physically on one ward, not going to others, splitting the teams most of the time, trying not to travel across low-risk inpatient units to high-risk inpatient units. You can see here our medical team from last year. I'm in the middle, maybe you cannot recognize me. That was what we usually, initially, we were going in an inpatient unit to work. This is what we have to change. Everything I had to just through mask. We had to keep all the guidelines of the government about how to just be in the unit. And of course, lots of shifts, cover for other doctors. As we say, we came to a very difficult situation, every one of us, that starting feeling the burnout. There's ongoing demands of mental health professionals, especially in income services in the UK, especially right now. It gives this comes from a year, very difficult year. We just had a discussion last week in our unit, was saying how we're going just to deal from now on, because we managed until now, but what is happening from now on that we don't see to reduce any of the demand of the admission in patient hospital, and we're quite tired and quite traumatized of what happened last year. As you see, there are lots of, as I said, estimate demands in the future. We don't know if this will be the case, Dr. Strigaris said, but overall they say that at least the inpatient admissions will increase to 13%. That is quite, actually, it's a huge percent, and we'll hope not to be true. They say about 2021, 2022. We're here to see. However, the current situation, the current reality in UK, in Northeast, that is my unit, the Orion and Nova inpatient units, there are almost 14 kids and they're sectioned and waiting a bed. So these kids, they cannot find a bed in the area. However, we are a national service, so we go through the national demands, and we admit young people according to the risk and to the severity of mental health problems, not about the region and how locally they are in our unit. So last week we estimated more than 80 children, young people in crisis waiting for a bed in the UK. That means these kids, they're in a high risk to actually deteriorate massively, and we don't know where to go. We don't have beds and this is quite impressive, they end up in A&E and they wait there for days and days until a bed become available in a psychiatric unit. As I said, the level of self-harm had decreased, the risk to self, suicidal intent, the plan has increased, risk to others has increased too. We have good news, of course, in the UK. I think you all know that we're in a good, situation now. The UK vaccination program helped a lot. We've seen now the end of the tunnel, not only the light, we see at the end of the tunnel. The good news is our staff, 80% of the staff has been vaccinated with the first and the second dose. The other good things, and we agreed, there was an agreement with the NHS trust policy to offer vaccination for our 16, 17 years old young people with capacity. And currently the young people in our treatment in our hospital, there are more than 75 agreed to and consented to vaccinate. So we've done that. Of course, all this data and all this research and surveys ongoing. I think more and more we'll see the impact of the pandemic in the near future, how all the inpatient units have just went through this experience. However, we have, as we say, a quality network for inpatient camps unit from the Royal College. Is called UNIC, and every year we have a meeting and then we go through all experience of the data that we recalled, or everything that has to do with the inpatient units really. It's supposed to happen last year, but of course you understand June last year, but of course it was cancelled. Now this one is the 17-18 of June, and our unit will participate as well with our clinical model that we just developed even through the pandemic and related to the ARC trauma informed approach. And of course, this is the end of the presentation. Please let me know if there are questions, and I would more than happy to give me feedback in my email address. Thank you very much.
Thank you, Anastasia. Thank you, Dr. Tsakiri, for your excellent presentation. Before begin addressing questions, I would like to give the floor to HAPA President Philip Kandilis for his own commentary. Philip, please.
Thank you again, George. A pleasure to be following this this group, and you've triggered so many interesting questions for us. I will be thinking about unpacking these for months. Let me start first with Dr. Tsakiri, who I'm in a public hospital to thank you for your work on the front lines there with the child and adolescent mental health services. This is extraordinary work that you're doing, and being able to do it with less staff and having to wear all the protective equipment and not having visitors and having our own families at home to deal with, and children and education. Really remarkable work. And I should tell you that our colleagues too are telling me, our child colleagues, that the admissions are down, but the length of stay seems to be greater for us too in the U.S. And as you pointed out, it may have to do with this idea of access to care. And for us in the public sector, we work with poor people, we work with distressed neighborhoods. This issue of who's getting admitted and under what conditions is what matters. So the girls, the teen girls, the girls of color, the ones who are uninsured. For us, we have an uninsured group, which is a little different than socialized medicine. So that concern with the vulnerable groups within the groups is of particular poignancy for us, and I appreciate your bringing that up. I'm particularly interested in how Greece and the United Kingdom are doing in telehealth services, because I understand the infrastructure is hard to develop in Greece and certain of the neighborhoods, certain of the areas of Greece. But in the US, it's been very useful in getting access to healthcare. So, you know, the rural populations, mental health populations, people who don't have transportation, all these things matter to us. So I very much appreciate the emphasis on unmet needs and the strain, both moral injury and not of this pandemic on your team, and thank you for that. Professor Xenakis, again, thank you for the data. I'm an outcomes guy myself in public health. We're always interested in trying to figure out what the burdens are and where the problems lie. And because we deal with poor and non-dominant communities, we're very interested in unpacking where the resilience is and where the positive and negative effects lie. One of my residents is doing a review of the past pandemics for suicide rates and how that matters, how that differs by region, by access to healthcare, and by the political atmosphere, where perhaps the politicians don't downplay the epidemic or they encourage mask wearing. These kinds of socio-political effects will have a difference. So I wonder, as you unpack the data, as we all look at how the data plays out after the pandemic, where these pockets of resilience will lie and where the effects are. And again, I suspect that it's among those who are challenged to begin with. So those who have difficulty with access to mental health care or have a mental health burden to begin with. My resident was looking at the Asian flu pandemic in the 50s, as well as the great 1918 flu, and noticing that sometimes the suicide rates went down if there were alcohol laws in place, so that there wasn't as much drinking during the pandemic, or if there was a vaccine available and it was early, that community did better. So all these very interesting ways of unpacking things will give us the kinds of answers that your section studies. And again, for those of you who are not familiar with the complexion at NI, it's the kind of modeling, and just so you know, I worked with the chief statistician at the clinical center for many years, Bob Wesley, who's recently retired. So I very much appreciate the kind of statistical modeling and the mathematical modeling that you use to help us understand the biological markers of mental health. So kudos to you for this work, and I look forward to the unpacking that you're going to be doing over the next months to years. Finally, for my friend General Xenakis, this idea of moral injury is so critical to us in understanding things may or may not be syndromic, whether they fit something or not. Something is going on. And the absolutely critical importance of addressing patients where they are vulnerable, and how they, out of their experiences, is one of the fundamental reasons that psychiatry exists. We are just, as your neighbors in the community, as your colleagues, we are so grateful that you're looking at this trauma informed approach to the pandemic, to war, to all the different kinds of stressors that our colleagues, that our war fighters, that our frontline workers in the pandemic go through. And for me, again, in the public sector, this idea of trauma-informed care very much coincides with this focus of the kinds of trauma, whether you call it PTSD or depression or suicidal risk. This is the vulnerability. This is the critical focus. It has to be a patient-centered, trauma-informed approach to care that you're describing for us, and that has so much meaning for. I mean, the idea that hopelessness and despair are part of moral injury is entirely reminiscent of the refugee experience, of the Civil War experience, the immigrant experience, you name it. So just wonderful. This emphasis of vulnerability from each of our speakers is, again, it's the reason we do this work. It's the reason we're in the pandemic, we're on the front lines, and the reason that we get together with these wonderful webinars. I will leave it there for time for questions. And again, to thank my colleagues for speaking and my friends for putting this together. Thank you, George.
We have some questions for the speakers, and some were answered by General Xenakis, and maybe he would like to go further with the discussion. And the question was if he has data regarding the use of technology, mainly the artificial intelligence and telepsychiatry for burnout or PTSD during COVID, and what your experience bonding these two on these benefits or losses using them.
Well, my experience has been very good. I actually had the opportunity now almost 30 years ago because of my job and my command. I was a commanding general for all the Southeast Army medical and for those forces, medical forces we deployed to Latin America and the Middle East, to set up a laboratory to develop many of the telehealth capabilities that we're seeing now. We could do that in the military. We did, interestingly, our first telepsychiatry visit in '88. It was very useful for us because we had a training program in child psychiatry at our hospital medical center in Augusta, Georgia, and we supported community hospitals all the way from Kentucky to Alabama, as well as others in Georgia and other locations. And it was that did not have child psychiatrists. And it was the way that we were able to get consultation from our child psychiatrists to the pediatricians. So we further went and developed that. I've been a big proponent for many, many years. And this COVID pandemic has again brought to light that we need to have those capabilities. And we do that very much. We've used them extensively. And the other hospitals and clinics that we've consulted to, we've guided them in being able to set up those systems. There are times when primary care providers need the consultation of various psychiatrists and specialists. And I think this is a very effective way of doing that. It also means that there's times that you need to have a other specialist, and I was interested in Dr. Tsakiris' note about they're doing primary care, general medicine. So you have a psychiatrist that's in a situation and they really need the consultation of an infectious disease specialist or some other, or a pulmonologist. And this is the way that expert is going to now guide the care of that frontline provider. So it's like everything, it's not only what you do, is how you do it. These systems have to be designed in a way with certain flexibility. There needs to be open feedback loops. There needs to be an understanding that people, when something does happen and there is a problem, that there is a correction, a mechanism for that. But look, I think that we should be using these. I think they can be transformative, and we should be very energetic and using them widely. I feel strongly about it. Let me just also make a comment that now about, oh gosh, how time flies. 15 years or so after I retired, from the Army and had really started to build these systems, I worked with a Greek surgeon who was at Yale, and he was very interested in trying to set up such systems in Greece. He said there are any number of villages and small towns that have really few doctors, and that the fact that really rely on the recent graduates from the medical schools to go out there and serve the patients. And it would seem natural for these doctors to have the backup of the specialists from their medical school or their larger medical centers. And so we worked to try and lay that out. And this was maybe 2003, 2004, and see if we could work with the government leadership to do that. From what I can tell, it just faded away. We were not successful. But I know that as I've gone and visited family and spent time in Greece, it seems to me that it would be something very important, knowing how the communities are laid out and what their resources and capabilities are, and particularly when you look at the islands. So I think there's a lot here, and I think that it should be a way that I encourage people to sit down and think hard of not doing it in psychiatry, but also general medicine. I think we need to be looking a lot at a more holistic approach to treating our patients. Thank you. Hope that wasn't too long an answer.
Yes, thank you for your answer. And we have another question for General Xenakis from Dr. Economou, the president of the Hellenic Association of Professional Psychiatrists. If there is any particular psychotherapeutic approach you prefer when treating and coping the moral injuries?
So that's a more, you think that was a long-winded answer? This is even a more long-winded answer. I'm an old man, and I've been doing this now for 50 years. And over the years, I have worked with so many different patients, soldiers and veterans and victims of trauma and torture. I think as Phil knows, I've spent a lot of time in Guantanamo, and I've spent a lot of time in a number of the countries around Greece. I've conceptualized it, but what I've learned is to do what I think works because of experience in psychodynamic therapies, including psychoanalysis and behavior therapies, and some understanding of psychopharmacology, but also because I, as a military physician, have spent as much time in general practice as I have in psychiatry. So what I do is rather empirical. The first step, and absolutely the most important that I have felt, is rapport with my patients. And that is almost easier said than done. That requires for me to be as honest and transparent as I can with these people. It's not like I tell them about my life or what is concerning me, but that I'm as straight with them as can be, and that they can be straight with me and ask me anything and challenge me on anything and tell me where they think what I'm saying is not right. And that also, if there's not a fit, but there has to be a fit. We have to know where that fit is and where it isn't. And I need to know, they need to know that I'm, one, very committed to to them as individuals, that it's not the role as a doctor and their role as a soldier, as a patient, that there were two individuals with a whole history of experiences, a wide range of experiences. And we're going to come at this with all the energy that we have to try and help them. And we're going to take all the best ideas from my vast, maybe not so vast, but at least all the years of experience that I've had. And we're going to think about how this particular intervention or treatment might be good for them. And if they think it's not, or they've tried it, then we will use that and rethink what our approach is. In some way, it's how you solve problems, military problems. You have a clear vision of what's going on, you're empirical, you're practical, you use feedback, and you adjust, as we say in the Army, you adjust fire as the situation requires. So that's, there's a lot to be said here, and I'd be glad to talk to anybody who has patients that they would like to share their experiences.
Thank you. Another question for Professor Stringaris. Professor Stringaris, could you please explain the data you presented that before and after the pandemic, there is no reliable pattern of change in depression and anxiety of youths, and if you have recognized any particular resilient factors of youth?
Thank you. It is a very good question. We should be better able to answer this question in the next 6 months or so, I guess, as we gather more data. Questions about resilience, if one wants to answer them on the basis of data, are quite hard to answer because they require a lot of statistical power and therefore very big samples. And the reality is, the sad reality is that there aren't many data sets where we have good quality data before and during the pandemic. So what we have, we'll have to pull together and see what happened. What people don't realize is, and you see this in clinical practice as well quite a lot, you see parents bringing their child to you and saying, oh, he's been doing so terribly badly since the pandemic. And you think, okay, that may be because of the pandemic, but just create the counterfactual. Children were coming to my office last year as well, and the parents were saying, oh, he's been doing so terribly badly since that party that went wrong, or since, they were expelled from school or whatever. So we attribute causality as human beings to the most obvious causes, what we think are the most obvious causes. This form of psychological causality, though, is not necessarily causality in the physical sense, if that makes sense, in the actual sense. So going back to your question, I don't know yet. From our own data, there was no discernible pattern of resilience. But I think that what Professor Kandilis said was quite poignant, that those who did worse before the pandemic are more likely to do worse during the pandemic as well, right? It's like you start from a worse situation. So you can imagine that if all of a sudden you are a single parent and you work at a supermarket as a cashier at the supermarket, and all of a sudden you're the frontline worker and the breadwinner in the family. Your child can't go to school because the schools are shut, but you still have to work in that supermarket and get exposed. I mean, who's more likely to be stressed? That person or the person who can work, I don't know, at Goldman Sachs and can telework and still make a lot of money and, and have a nanny look after their children? It's just the chances are higher that things will go worse in groups that are disadvantaged. It's just this way things are on average, right? So no, I don't have those intensely into them, and we hope that we will be able to tell you more as we pull together more data.
Okay, thank you. Mr. Kandilis,
I just wanted to make a connection because I think that the question is from a member of the team that we were working with, Mr. Karampoutakis' team, and if I understand correctly, this is from Ms. Farouni. I'd like to draw a connection from the resilience work that we do when we come to Greece and work in the refugee crisis and the data that Professor Stringaris is developing. But I wonder if Professor Stringaris can draw from the burnout or from the refugee data to say, there are some techniques that we anticipate we will see. So if you have more supports, if you have more access, if you have some technology where you can take a break, where you can do some mindfulness, whatever the usual resilience is, whether it's psychological first aid, Ms. Faruni, you'll remember we talked about that kind of thing on the beaches of the refugees and the islands. I'm hoping that we'll find some parallels, because a number of you, if not all of you, have talked about burnout as well. So as we burn out, we're going to be applying the very same resilience techniques that we are expecting to see. We can test these hypotheses as Professor Xenakis analyzes his data. But is there a connection to be made there, Adjunct?
Well, yeah, these are very good points. I think that one kind of the bigger context, right? And there are those part data things about how people respond to warlike situations, how populations respond to warlike situations, like what in Britain they call the spirit of the Blitz, right? And this is a kind of a general contextual factor that people will pull together and say, well, we're all in this together, so we'll just go through it. We'll go through it. That's it. And I think that certainly there was certainly a little bit of that at the beginning of the pandemic. I don't know how sustained it has been, and whether it's been sustained in many regions of the world, or, for example, within the United States. So that's one very general factor. Another factor that is also public health related is how the government communicates information, and whether it communicates information in a way that is going to buffer some of the mental health consequences. One of the important ways of mitigating, of controlling anxiety is handling uncertainty. So we as humans don't like uncertainty. In fact, our brains are in some ways uncertainty reducers. We're trying to reduce uncertainty, right? So the job of a government and the job of is to kind of make things be more certain or appear more certain and more controllable. So instilling a sense of agency is very important, I think, both at the public health level and also at the individual level. Look, you can actually do X, Y, Z to help with that. The third thing I would say is structure. So I'm talking about very simple stuff, not if you have the opportunity to do lots of psychotherapy with someone, but if you had to give one piece of advice to a young person or a family, what would it be? Well, it would be something like, make sure that when you get up in the morning, you've got something to do. You wake up and there's some purpose. Then make sure you can have a meal together or something like that, so that there's some structure to your day, because there's nothing worse than everything kind of being a bit of a mess. These are some very general low-cost principles that I think could help during the pandemic. Have I done a randomized controlled trial of this? No, I haven't. So what I say with with due deference to reality and its harshness. So it's more experience and kind of common sense, I think.
General Xenakis raised his hand.
Yeah, I'd like to just add to what Adjunct said and Phil asked, because these are principles that we have used as leaders in the military. I mean, these are just basic, and the program that we've designed at Silver Hill Hospital has been to educate our communities and the leaders in our communities to use these principles from many, many years of operations in combat to be able to survive the pandemic and other challenges that people are meeting, and to be more resilient. So leaders are responsible for giving guidance, for knowing what the mission is, in that sense, to help people wrestle with ambiguity and uncertainty. We know that it's going to be uncertain. That's what leaders do. That leaders build teams. We need to have, and we need to bring in that our frontline managers work in teams, and that they now need to make sure that their teams talk to each other. People need people working in a situation. I think it helps a lot with burnout. There's nothing like going in the days where we had these situations and we could walk around, is going to an emergency department or going to some area that you know is getting overwhelmed and having people talk to each other and to have routines and to know that they're going to check in with each other, they're going to check out, that there's going to be times that in order to do self-care, that there's exercise. A big issue here is sleep. I think a lot of people need to be trained in how to manage their sleep and get through these stressful situations. And there's some very good techniques out there. So all these are principles. In fact, I kind of wonder how one designs any kind of study. You know, good leaders have been doing this for thousands of years. And I think it defies studies, yet we know that it works. And all you have to do to be a good leader is to just follow the traditions. Just do what you got to do and care about your people. I think that's what it takes here.
Thank you, General Xenakis. And we have another question from Dr. Gikas from the Smart CNS Center for Dr. Chakiri. He would like to ask, how did the mental health professionals cope themselves with the increased responsibilities and changes of their daily routine in a demanding inpatient unit as you described? And if you had any kind of help from the NHS or the UK government?
Thank you, George. Well, I think I will agree with Dr. Xenakis. Now we talk about everything is related to trauma approach. I think even professions, the way to change the narrative as well. I think now we don't even talk about disorders. We talk about conditions, about presentations. So this comes, of course, to mental health professionals. From the team that I saw you, actually, both the doctors had resigned after 6 months. They went back to their countries. It was quite hard. NHS helped a lot. We have lots of links with other inpatient units through the QNIC and through other forums. So because it was unexpected, we haven't seen before this kind of situation, and mental health had to deal in a different way with telemedicine, video calls and everything. So it was quite good to see that our clinical directors, our lead clinicians, and of course the trust helped a lot. So they provided at the beginning even with hotels just to have to stay, not to expose our families in the COVID, because we are in a hospital. So a hospital is a hotspot of COVID, was hotspot of COVID most of the time. We had under the privilege to stop admission, to close the hospital admissions with in agreement of NHS commissioners, managers. And actually now we had a crisis last week and we closed admissions. So this is quite a privilege for a hospital and a new hospital as well. And the professionals to be to provide with hotel if they need, so to stay close to the unit if they don't want to go back to the families. With meals, we had support from a lot of charities and a lot of NHS trust committees about giving us meals, because if you stay in a hotel, and the hotel had to just close most of the time with the restaurants and everything. They provided only the beds to sleep. So it was quite impressive. And I must say it was quite impressive the help and support that we had, the nurses, the staff, the clinical staff, or with each other. So we have team time, as we say, briefing times. We have a reflection time in our unit. We use the ARC model as well as with professionals, because it's a traumatic situation. If you, first of all, to go every day in this high tense environment with COVID. So it was quite, I think I used to work 10 to 12 hours every day. It was quite a lot of time. We had to deal with all these new things. We had even to do mental health assessment through video calls, and the AMP practitioners to be, you know, somewhere in the UK because they couldn't manage to travel to the unit. We have tribunal videos. So to help professionals do their jobs, by that be protective, be standard. The more staff that went off sick, the more problems we had in the unit. So, yes, I think it was quite, I was impressed as well, because I didn't expect so much support from not only the trust, but other professionals as well. Thank you.
Thank you, Dr. Tsakiris. We don't have any other questions. And before I give the floor to Dr. Karampoutakis to close this meeting, I would like to remind all the attendees and invite them to become members of the Hellenic American Psychiatric Association, to be informed for future initiatives, both virtual like this one, and hopefully in the future in New Orleans next year in the APA meeting in person. Dr. Karampoutakis.
Once again, I would like to thank everyone for being here. I am very grateful to our presenters and to our colleagues attending. I know it is still a holiday, and it was a difficult day to hold the meeting. So your presence is that much more appreciated. Hopefully, we will soon have another opportunity to meet, perhaps even in person, if COVID allows. Thank you once again. Christos Anesti, and have a good evening and καλές διακοπές υπόλοιπων διακοπών. Ευχαριστούμε πάρα πολύ αυτή την ημέρα.